And although my work here at Queensland Brain Institute focuses on decision-making problems in psychotic disorders, I think it's really important that we all understand mental illness better and learn what we can do to improve our own and other people's mental well-being. So for this year's webinar, we're going to be discussing the science of depression and anxiety. Before we get started, I'd like to take the time to acknowledge the Turrbal and Yagara people, the traditional owners of the land we're meeting here today. We'd like to pay our respects to their elders, past and present. Given we'll be talking today about mental health, it's important that we're all aware of the crisis support phone lines and programs that are available to us, which you can see on the screen now. So for those of you who aren't familiar with the Queensland Brain Institute, we're in our 19th year. We have over 400 scientists working to unlock the mysteries of the brain. Mental health is one of our key areas of research here at QBI, and we have researchers looking into the genetics, developmental insults, and neurochemical abnormalities that contribute to mental disorders. Now, I'm really looking forward to today's discussions. Great. Now onto the science of depression and anxiety. We typically spend a third of our lives working. That's a lot of time. But how does the workplace impact people who suffer from depression and anxiety? We have three experts with us today that span the lengths of fundamental research to mental health policy to treating people with a variety of severe mental illnesses. We have Dr. Susannah, Dr. Sharon Ponniah, and Adjunct Associate Professor Alexander Lim. They're going to share their research, insights, and experience with us today. So thank you for joining us here today. So our format today will consist of a short presentation from each speaker. As a perk of running the whole show, I get to ask them one question each. But don't worry, you'll all get your opportunity to ask questions when we open up for discussions at the end. So please submit those questions and submit them throughout so we have them all at the end, and we'll get to as many as we can with the time we have. So up first, we have Dr. Sue Tai. Dr. Tai leads the Functional Neuromodulation and Novel Therapeutics Laboratory here at Queensland Brain Institute. She's looking at how stress affects mental health and brain health, and how disruption of stress hormones can affect recovery from depression. Over to you, Sue.
Thank you so much. So my research program is very much focused on better understanding the factors that contribute to depression and anxiety from the perspective of how we can improve treatment approaches for individuals. And one of the really exciting things about the research at the moment are the paradigm shifts that we're undergoing. And for a long time, mental illness has been considered to be a disorder of the mind. And one thing that our research and research all around the world is really helping us to better understand that beyond the mind and underpinning that are changes that are happening in the brain as well as the broader physiology throughout the body. And this is becoming increasingly important in being able to target these mechanisms with treatments that help an individual, because of course these factors are different for different people. For a long time, and based on what we understood about how antidepressants worked in depression and anxiety, we've considered these disorders to be disorders of chemical imbalances, a serotonin deficit, for example. But we now know that that's just one part of the process, and that's not necessarily the case for every single individual. Instead, we understand that these are disrupted cellular functions within the brain and within the body that impact the way the brain is connected and functioning, so the circuits within the brain that are contributing to some of the clinical features of the illness, as well as the systemic factors that are impacting the illness presentation. And we also understand that beyond being an acute disorder, so an episode of depression or anxiety, the greatest risk factor for having these illnesses is having had a previous episode. So even though the presentation may be episodic, it's much more effective to think of long-term risk, chronic management, and protection and prevention of factors that can contribute to that vulnerability. And again, looking at some of the sort of reverse engineering of what we're seeing from the clinic to our understanding of the neurobiology of these disorders, we've seen treatments that took weeks to months to be effective can now be replaced, or alternative options are available that take hours to days. And so in these instances, there's a very clear biophysiological mechanism at play that can be targeted by effective treatments. And so our research questions are really around how can we understand what that mechanism is for each individual so that we can improve treatment outcomes in the clinic and help clinicians get to that point much more rapidly. And one of in understanding or looking at these mechanisms, one way to work towards that precision medicine and promote protection and resilience is really to look at understanding what's happening at an individual level. So the neurobiological circuits that I referred to a moment ago can lead to different presentations of the illness. And so understanding how the brain connects to and underpins some of the symptom profiles can help more effectively intervene in those states or protect against them going forward. One of the things we're very interested in is helping destigmatise mental illness. And so the physical symptom profiles are very much part and parcel. They're part of the diagnostic category criteria for these disorders, and again, underpinning the really important physiological mechanisms that contribute to illness presentation. And because these can be different for each patient, a diagnosis of depression or anxiety, for example, is not necessarily enough to understand what it will be the most effective treatment. And this is a really exciting paradigm shift in the field that we're moving towards, is these precision medicine approaches. And so our research is looking at how we can better understand how to get the right treatment to each individual, or how to protect against repeat occurrences and build resilience by understanding the inherent vulnerabilities at the level of the brain and the physiology based on the symptoms presented. And our research focuses a lot on stress and how the stress hormone axis contributes to dysregulation of these symptoms, as well as the leading to resistance to antidepressants. So we know that by shifting some of these, the regulatory mechanisms within the stress hormone axis and the circadian rhythm, that can increase risk for treatment resistance in depression and stress and anxiety related disorders. And I've included this figure here just to highlight that these are very interdependent systems. And so we know that there is increased risk for cardiovascular disease, metabolic disease, dysregulation of sex hormones and immune function. But all of these factors are working together, and so looking at mental health as a function of brain health as well as physical health, I believe is going to become increasingly critical in moving forward, not only in protecting and providing resilience, but also in facilitating or augmenting interventions that are available clinically. And in our research, looking at how chronic stress leads to this HPA axis dysregulation, we find that one of the key factors that's dysregulated and links a number of these different systems is activation of the inflammatory system and overall disinhibition or dysregulation of this system. And so this can be chronic and low grade and may not present clinically, but it can contribute to some of the symptom profiles that are seen, such as fatigue and apathy. And again, is at that interplay between this increased risk for chronic and comorbid disorders that we know that mental illness is an increased risk factor for. And so we now understand that rather than being separate entities, that the brain function is directly impacted by dysregulation of these physiological systems. The neurotransmitters are affected, the synaptic plasticity and connectivity is all affected, and that through these mechanisms it's contributing to these other risk factors. And so when our treatments are acting on this, or when we're looking to prevent getting to this state of overload or burnout, that whole body health is a really critical factor in that, and stress management becomes a critical part of that equation. So in getting back to the workplace, appreciating the importance of time away from work, time to rest and relax and rest and repair, time off to let the immune system rest and recover as well, becomes increasingly important to managing all of these factors working together that are increasing risk for mental illness. And so our research has shown this interplay specifically as it relates to some of the symptom presentations, and we believe this is going to have impact for precision medicine going forward, particularly in the very treatment-resistant stages of illnesses such as depression. We've seen that this chronic stress hormone dysregulation does increase deficits in motivation. It causes a state similar to anhedonia. That's associated with and causes a decrease in the availability of dopamine in the regions of the brain within that network that are controlling motivated behaviours, attention, and energy regulation as well. That these changes in the brain are associated with elevated levels of inflammation in the peripheral circulation, and that in turn correlates closely with the change in dopamine availability as well as the behaviour, and an increase in inflammatory load even within the brain itself. And so we're very interested in how these factors will be able to be utilised going forward for precision medicine approaches. We find that some of the novel treatments for depression that are effective in treatment-resistant depression are acting on these very mechanisms, and so we're excited at being able to move forward and take that towards the clinic.
I think that's a great summary of all the complex interplay between physical body and brain in some of these disorders. And I think personalised treatment is something that many people are starting to think of, especially with regards to cancer and other disorders that are quite specific. But do you think in the terms of these types of sort of chronic disorders with that stress, is it going to be precision medicine in waves? Here's what we need to give you now to get over this first period, because we've got to reset some of these things. Then once you move into a more sort of stable environment, then this next treatment might help you get through that next bit until we can wean you off that. Do you think that's that course of precision medicine rather than just here's your cocktail for?
Absolutely. I think in understanding that these can be progressive disorders, they can also be, it's progressive in terms of the recovery process as well. So it's not a one size fits all for treatment, and that's amongst individuals as well as within the individual. So adapting the treatment to the stage and state of the individual is going to be very important, and making sure if, for example, treatments are being prescribed, we know that they're working on the brain, they're causing adaptations in the brain. And if the brain and the body are busy dealing with this overwhelming inflammatory load, an individual's under pressure, not getting enough sleep, that the brain doesn't have the opportunity to adapt the way it should. And so factors such as synaptic plasticity and repair are limited. And we think that's one of the reasons that underpins treatment resistance. And so targeting those mechanisms can help with that recovery, and then other factors can come into play. And that's where there's more opportunity to engage in the psychotherapy, for example, when the brain is more adaptive and the body's in a more responsive state.
Fantastic. Lots of things to look forward to. All right, so next up we have Dr. Sharon Ponniah, a partner for Health and Wellbeing, Public Policy and Economics at PricewaterhouseCoopers. Sharon has worked across the public and private sectors, managing research, evaluation and population health programs in both Australia and New Zealand. She currently leads PwC's Consulting's mental health business, supporting public policy reform in digital mental health, workforce and workplaces. Thank you, Sharon.
Thanks, James. So I'm going to take this in a slightly different direction here and talk to you about public policy in terms of the bigger picture that public policy offers, but also have a real focus on what this means for workplaces and for employers in particular. So, there is a big public reform agenda in relation to health services, but also in relation to mental health services. And there's a lot of work we need to do to increase access to coverage for all the spectrum of mental health. And when I say spectrum, I mean it's people keeping well as people who need help. And we're very reliant at the moment on some traditional forms of providing that access in terms of services, and very reliant on psychiatry and psychology. And so when we think about the reform agenda, how do we start to move a little bit of our focus, actually not a little bit, a lot of our focus further upstream to start to be more preventive in nature? And I think there's a real link to science and how we translate that into policy so that we're better informed and really folding that evidence into practice. And workplaces have a big part to play here. You know, the very nature of workplaces has shifted in such a short space of time. You know, look at what COVID has enabled us to do in terms of using technology really effectively and well, but also those repercussions of being locked down, losing some liberty and freedoms and the ability to choose, not being able to return to home, country, to place where there is a strong connection, and to see families, for schools and children being locked down and, you know, being away from those social connections and those milestones that you hit through life course and life stages. Many were really diminished for many people. And so there's a regulatory sort of legislative pressure here. When you think about workplaces, you know, legislation is changing, and I'm not the expert on legislation, but there will be more of a risk-oriented approach to understanding what are some of these hazards in the workplace in terms of psychological risk and safety. How do you identify those? How are they changing over time with the nature of hybrid working? And you know, there are some industries that do this really well, in the mining sector, for example, in the construction industries. But there are other industries for whom, while this has been part of, you know, occupational health and safety for a long time, it's really becoming more direct and overt in terms of the need for workplaces to do a little bit more. And so there is a duty of care, and that duty of care in relation to workplaces does move from the risk space and needs to consider things like your culture, your tone, your leadership, your ability to provide connection and meaningful connection. Building capability in the workplace, and I'll talk a little bit more about that as I go. And also having the right policies and structures that are evolving in a contemporary way so that they're more fit for purpose as we learn more, because we are all still learning as we go. And then really critically, employee expectations are changing. You know, people want to see more from workplaces and their employers and what they want us to provide, but also the nature of the support offering that we're able to provide. And as that happens, there's a real pendulum swing I'm noticing with many people I speak to across all industries in terms of that sentiment. So, you know, our workplaces being more responsible as we're thinking of environmental responsibility through to social responsibility through to governance. You know, there are all these factors here that workplaces will need to grapple with further, and that'll all move pretty quickly in a bit of a domino effect I sort of expect to see in time. Now, there's a lot of data out there which I won't read out, primarily because I can't read it. But the key messages there are that, look, there's a very positive return on investment for workplaces to invest in this. So for every dollar you invest into primary prevention and into offering support services, there is a $1 to $4 return on that. And so it's a bit of a no-brainer in terms of you need to do something, but how do you make that something go further and consider the nuances of your workplace, the settings your people are working in, what are they exposed to, and how are you building some of those more leadership, diversity and inclusion practices and cultural elements into play to start to create a mentally healthy workplace. So this is very much about a strengths-based approach here. Now, I think some of this data is quite interesting, right? This was a nationally representative survey that PwC ran through our Future of Work practice. And some of the statistics that I kind of took a step back and was surprised with was the number of people who expect to receive support services through the workplace. You know, for a long time, I think we've assumed that anonymity was key and that people didn't want to disclose in the workplace for fear of career disadvantage, for fear of not being able to, not being viewed in the same way. And I think some of that is changing. A lot of it will still be true, but some of that is changing. And I think there is absolutely an expectation to receive comprehensive services and a lot more choice to be available in workplaces. And then there's a statistic up there around the number of people who would favour a more balanced approach versus promotion and versus you know, increases in salary. To keep their job, keep themselves well, and you know, keep doing purposeful work that is meaningful to them, and really making those trade-offs and choices, which I think is interesting to see in the data coming through as well. So look, a lot of the, I guess, advice and guidance we often give to workplaces and employers that we're working with is around really lifting that capability. And I often describe it in three ways. One is around, the systems, the policies, the procedures, the guidelines and guardrails that you put around what you design. There's do you truly understand your people? And so there's a difference with executive leaders, there's a difference with managers and team leaders, and there's a difference with individuals. And if we start with individuals, we often don't design these policies by listening, hearing, building that lived experience into the mix. And I think starting there will be a fundamental game changer for what we're then able to create and respond to in terms of the real diversity of needs out there. With managers and team leaders, I think a back to basics approach around how do you build that capability around understanding of mental health and what that is. How do you approach a strengths-based approach into how you manage people? If you are managing someone with difficulties and experiencing mental health challenges, whether it's through a diagnosed condition or not, how do you separate that from a performance-related issue versus being able to understand how this person is experiencing and hearing what is being said to them? How do you navigate some of that? And what are the support options that you can responsibly be across? And it's okay to say, I don't know. It's always okay to buy some time and go away and do some research and come back to the person. But really, I think we've got so much at our fingertips that we can draw from. And providing that curation and consolidation with a trusted person can really go a long way. And then with executive leadership, which we usually start with first, it's tone from the top. It's walk the talk, and how do you go beyond saying that this is the right thing to do to starting to embed some of these principles into practice. And we're starting to see a lot of change happening, largely led by the corporate sector. But as we sort of walk through the different industries and the different industry needs, different things are going to start to surface. If I take healthcare and social care as an example, it's a very female-dominated workforce, and there are going to be differences in the needs and the migrant populations that we're bringing in to fill the workforce while we've had tensions in meeting workforce supply needs. And that'll be very different for the construction mining industry. So, all of these things mean that there's no one size fits all. And so we are going to have to tackle that from a place base, from a person base. But there is a lot of evidence that we can draw from to inform that you're heading in the right direction there. And I think I'll stop there, James.
I think that's all really interesting. You mentioned it, it's all the hierarchical type thing. People at different levels have to be approaching this the right way. Aside from coming to speak to you, how can someone who's interested, I think we have a lot of goodwill for this type of this movement forward, how do executive and leaders and even employees find out about some of these strategies and tools? Is there online resources or is there places to go?
There are. So the National Mental Health Commission at the moment is working on what they call the National Workplace Initiative. And so it's in a beta site at the moment, but eventually it will house evidence-based and best practice tools, templates and guidelines for anyone to access. So it will be free to access. And that will grow over time as well and become more categorised so that if you're hopping on, for example, James, and looking for a very specific question, you'll be able to search for that. And so while that will take time, I think things like that, that's national level, but there will be jurisdictional-based elements for Victoria, for Melbourne, for New South Wales and beyond. That'll also be important, I think, just to navigate what is right for me and the different places we live.
Excellent. I look forward to that coming online. So our final panellist today is Adjunct Associate Professor Alex Lim. Alex is a clinical psychiatrist. He works with children, adolescents, adults and families, as well as trauma patients suffering from post-traumatic stress disorder. The founder and medical director of Z3 Medical Group, Alex has a keen interest in clinical governance and team-based clinical models. He encourages clinicians to work collaboratively to provide the best possible care for patients. The floor is yours, Alex.
Thank you very much. Thank you very much, everyone, for having me here. It's an important conversation to be having right now. I'm very much the customer of all of the influences that you've heard before in this panel. The current landscape that we have at the moment is quite precarious. We have a high prevalence set of conditions with depression and anxiety. In the training that I grew up in with low prevalence conditions of psychosis and schizophrenia, it's a very different ballpark. the impact of these high prevalence conditions affect right the way through society and systems within society. The workplace influences, the loss of productivity has been well and truly studied. The economic loss and gains through good practices equally important as well. Thinking more from a macro perspective, we have this as a really a worldwide phenomena. And we have a definite need to understand that the incidence of this set of problems of high prevalence conditions has a direct impact on productivity, whether it's the European study or the Australian study. It certainly affects high income, middle income countries as well, and translates directly into not just public policy and discussions, but also the individual. So the individual from an ecology of friendships and families, but also from a workplace perspective as well. And the system that I grew up in, where we had training very much in a low prevalence conditions and very hospital-based policies, quite different to the policy considerations at a more national and global perspective. Regardless of that, an important thing here is that the mind-body connection has been established for eons. We've known about the mind-body connection since the time of Descartes. And how that translates now into a public policy perspective, into recognizing that somatic conditions secondary to mental health conditions, that the mind and body are connected, and how we then develop scientific endeavors and also policies to reflect the impact of physical health concerns secondary to mental health, and the two-way interplay of that, I think, is really exciting today. Precision medicine, precision psychiatry, I think, is very much the clinical standard for the future. So if we cast our minds forward into the domain that I work in, where it's a little bit frustrating, our choices in clinical psychiatry are really limited. We have a general approach that says if you have anything more than a moderate level of a condition, we ought to consider medication. If we're looking at a particular set of conditions, one predicts the onset of another, and if you have two particular psychiatric conditions, the likelihood of a third is much higher, and so forth. Certainly, the interplay between physical medicine and mental health conditions are also very much there. And there are studies well known now that predict lower levels of health access, and also health outcomes if you have mental health conditions well in play. So whether it's in-hospital cases of schizophrenia, or in fact the much more high prevalence conditions of depression and chronic anxiety, the health outcomes for somatic conditions of cholesterol, diabetes, etc., are much higher. So if we then look at particular treatment modalities, what are my tool sets available and the effect sizes available to something that I commonly work with of PTSD? It's really a dilemma, because we really lack an understanding of what do we do when our tool sets currently don't seem to produce the outcomes that we hope it to achieve. So if we compare ourselves to our physical medicine colleagues, and I wish I had a therapeutic guidelines book that I could whip out and say, first stage, first treatment, we do this, second stage treatment, we do that, because I expect a stepwise increase of efficacy and effectiveness with each step. We don't have that. In psychiatry, we're also quite divorced from physical investigations in the main, because unlike physical medicine, we can't diagnose depression or PTSD or anxiety through a lab result. Love to do that one day. In terms of an example of PTSD, if we have a look at the modality of PTSD, what it actually means. The guts of PTSD is very much shared with depression and anxiety. So the specificity of what I consider to be PTSD is not quite as specific as I would like it to be. By comparison, if I said to someone, and general medical approach, not a psychiatric approach, that someone had a UTI, urinary tract infection, caused by a particular bacteria, the pathologist can very much inquire which particular bacteria, and is that bacteria sensitive to a range of interventions of antibacterials. And if this one doesn't work, the next step might work much more effectively. That informs for us a broader scope of effective treatments. Now, psychiatry comes into play, and what effective treatments are allowed in our tool sets, and what do we have at current? We don't have a lot of very effective treatments when it comes to treatment-resistant, name your condition. So in this case, treatment-resistant depression. By its own definition, treatment-resistant depression, in the way that it's currently thought, there are various definitions throughout the world, that we're looking at least a failure of 2 treatment modalities across a defined period of time, whether it's 3 months each trial or several weeks or several months. At some point, we have to compare to what are more measured treatments. So, for example, antibacterials. And certainly, the effect sizes, they just don't compare. And I would like it to compare one day, and perhaps the approach of precision medicine, where perhaps pharmacogenomics really come into play, so we can really design this and tailor this for the individual based on understanding of P450 cytochrome systems. And on top of that, the layering, so that, for example, research about antidepressants, SSRIs, and in the context of my particular population of active serving military and veterans, where the likelihood of musculoskeletal injuries concurrent with depression and PTSD. The likelihood of SSRIs working in those individuals are far less than those without inflammatory markers floating around. So if there's an interplay that we understand that is mind-body connected, and there's been awareness of this for several centuries, and we consider that our next step approaches in policy ought to consider the tailoring to the individual, we actually now have the perfect recipe, that we have the available in emerging sciences. We have the pharmacogenomics, we have the inquiry about the macro and the micro, and we have pharmacotherapeutics that might inquire about at the neurobiological end, for example, with suicidality. What is the cascade and how do we intervene with suicidality? So this very much is a beginning of a conversation that hopefully, with the effect sizes shown, that one day we might very well have an effective tool set that says, stepped and staged. First step, simple for very much simple, moderate level depression, complicated by very few psychosocial factors, uncomplicated by PTSD, inflammatory cytokines, that perhaps step 1 intervention is this, and we can measure that. And we can predict that the smallest set of interventions are more likely to be of use, but therefore, step 1, step 2, step 3, or phases of treatment with a better likelihood of outcome. And with a smidgen of luck and hope and collaborative care, we might end up having a prevalence of treatment-resistant depression that is far less and far much more toward the treatment-resistant bacteriology that we have. If we then consider, well, what do we have right now? And if we consider that research has led the way since, well, goodness me, for psychiatry and ketamine since 2002, the Yale research that has emerged and progressed right the way through the last 2 decades, how do we imagine the next steps might be, and what might we start to include? Ketamine is one of those interesting modalities, a tool set that really challenges our understanding of the pathophysiology of mental health and whether or not we can in fact articulate this notion of pathophysiology of mental health. And if we inquire into that phenomena where we've tried the conventional medications, we've tried the conventional approaches of psychotherapy plus medications as well, and there's a subset of 30 to 50% of patients where, for all of the well-intended purposes and following guidelines, they still have a very high degree of functional impairment and symptomatology. What are we left with? In traditional speak, we have lithium, we have mood stabilizers, we have ECT, and we have lamotrigine and potentially now TMS as well to intervene. Casting my eyes from a consumer's perspective, just last night I was a bit bored and I Googled, because I like to do that and keep an eye on the marketplace, and Mayo Clinic came up, a bit of a plug to the Mayo Clinic in overseas markets, and what they described was, if you have treatment-resistant depression, your options are, you have ECT, you have rTMS, and you have ketamine. And the evolution of ketamine to become included in any form of acceptable literature has taken its time. And from 2002, from Carlos Arradis's publications and research to where we are now, ketamine stands as a disruptor to the way we understand what is actually depression, and perhaps as a disruptor to our approach to understanding mental health writ large. If we accept that and hold that in our imagination, we might actually say that policy might need to shift to accommodate an availability to think about this in a different way. Maybe it's not entirely the monoamine theory that justifies the presence of depression and its treatments. And if, for example, an MDMA antagonism is one of the other pathways available, what do other studies such as ketamine studies inform us? And if we consider that, we might start to inquire about the broader approach, and particularly around tailored and precision medicine. So why ketamine? Why ketamine from a macro perspective and policy perspective? I'm a frustrated psychiatrist. If all I do all day is to pump out and prescribe more and more medications that predict a higher level of somatic considerations, such as further incidence of diabetes, increased incidence of hypercholesterolemia, lower standards of physical care because someone is now more obese, more likely to have further injuries, more likelihood of a reduced sense of life and livelihood. That's not really what I want to do as a medical doctor. So if then I inquired to the medical general community to ask, what are the mechanisms that I know about for my particular population of PTSD sufferers, military and veterans, knowing that there's a comorbidity of PTSD and after 6 months, depression, and within that cohort, alcoholism, as well as chronic pain, etc. And the DVA top 20 conditions informs you of all of those conditions that are very common. If we inquired into the common comorbidities of this population, we see the common pathways: inflammatory condition. We see the conditions that relate to alcohol and alcohol as a substance of coping. And so we have a population that is highly geared toward problem solving and self-adaptation, and alcohol might be very much a way of dampening down some of those symptoms, but in a maladaptive way in the long term. So how do we intervene in a useful manner? We've done the SSRIs, we've considered SNRIs, we've gone through those pathways, but at some point we still have a very large cohort of very unwell people. At that point, what do? I can offer the conventional next step treatments of ECT, but that has particular side effects particular to memory loss long term. Ketamine comes up as a possibility. And so back in 2019, my group spoke with the chief medical officer at DVA, and we had a 2.5-hour conversation, which led to the availability under particular policy mechanisms to fund, at the time, a very tentative pilot consideration of a ketamine clinic in Canberra. And it's really come to life. 2.5 years later, we've now treated quite a large population of people, more than 150 veterans and current serving personnel, fully funded. It's become a line item at DVA. What this informs me is that there is an available conversation to be had with policymakers that is well and truly connected to funding. What we are now wanting to explore are the research allocations, and we've spent a nice 9 months trying to get through and have gotten through now a very tough ethics approval process, and through DDVA, Human Research Ethics Committee, we've now got that. So starting February next year, our program will be under the scrutiny of 2 PhD candidates. What's important about this is that psychiatry is evolving. We have a set of conditions that is highly prevalent throughout society, that has a very high cost of economic burden on productivity in every middle-income country and high-income country, and likely globally as well. We have policymakers that need some guidance in terms of the science and research, and we also have a clinical community needing some guideposts and guardrails as well to proceed with precision medicine in every sector. So this provides, I hope, an opportunity for that ongoing question about how do we start a conversation that says having a treatment-resistant state is not good enough as a conclusion. It's a conversation opener to suggest that we need to inquire further. Interaction between clinicians and psychiatry and policymakers, and interaction between these three domains, I hope, might actually inform the training process for psychiatrists, but also the interplay between psychiatry, psychology as a team effort. The program that we now have is very much the team effort between GPs, psychologists, psychiatry, nursing staff, and it's a joy to watch. It's such a joy to watch. So to round this off from my presentation, the key bit from us is we had a question question, we have the beginnings of a solution, and it's now very much a multi-disciplinary environment that we've garnered. Thank you.
Fantastic. So in the interest of time, I'm going to ask one question of all of you now as I prepare for the questions coming in. You mentioned that the working collaboratively, you've all mentioned you have the same goals at the end point, right? What do you each think individually is the bottleneck for this collaboration to push forward faster, I suppose? Take that question however you like, but as a broad intro to get things started.
Yeah, I would say that it's going to take a team science approach, as a societal approach, to come together to do that. And I think, from my perspective, one of the rate limiting factors is actually having the opportunity to come together like we are today and have these conversations. Because there's a lot that we can share, a lot of cross communication that can occur. And the research that we do here can be informed by the needs of the clinic and by the needs of the workplace, and vice versa. We can provide some insight onto the role that things like stress have on overall well-being and treatment response rates as well. So it really needs to be that communication from my perspective. But interested to hear your thoughts.
It's a big question, James. And when I look at and think about collaboration, I think about it probably in two different levels. One is the system level. And so when you think about how we don't currently collaborate, governments don't necessarily speak to each other daily. And so quite often the right hand is doing something quite different to the left hand when they're intending to drive in the same direction. And so what that means then is that if we are embracing a multidisciplinary team approach, which I think we should, it drives the best kind of outcomes, how are we breaking down those barriers between nurses and physios and pharmacies and psychologists, and how are we creating an environment that incentivises them to work together? And there's a policy lever to that, there's a funding lever to that, there's just a natural, I agree that this is the right thing to do, lever to that. And so how do we bring it all together to make business sense, but also to make sense for how we design and care around the person? And precision medicine has such a big part to play in it, but there are so many factors to how we glue it all together, which makes it messy, but that's part of the fun of it too, I think. What about you, Alex?
I agree completely. I think the key bit here is culture. And in the training culture that I grew up in medicine, it's very siloed. And there were efforts at my university to create this joint endeavor and common purpose. It's tricky because the language of each health discipline is different. From a different policy and non-medical perspective, we can borrow some lessons learned from general policies in government about multiculturalism, and when I borrow from that domain of work from Canada and from Australia, we're now actually pushing this other question of, yes, I'm a doctor, yes, you are trained as a pharmacist, and you're a nurse. How do we bridge the language and the cultural expectations? How do we come together so that we can actually talk a similar talk? I asked this question to Head of Health and Defence, and what she replied was fun. It's got to be fun. And it's not really the economic lever or the business lever. It's got to be fun. I think that's it. I think one of the primary levers of why we come to work is because we enjoy working. And if at work we have these different conversations and we can have the cross-pollination because we all come from different disciplines, that interdisciplinary effect then comes to life.
So we've got to hang out more, basically. Right? That's excellent. I have heaps more questions, but we're going to open it up to the audience now. So I encourage you all to click on that little comments, submit your question, and put your name and email address with it as well. And that way, if we don't get to it today, we can answer it later. So we have one question, which is a bit of a government-based one. So there's a new bill waiting to be voted on in the Queensland Parliament, which introduces legislation which places more importance on government messaging and marketing on health above the doctor's relationship with their individual patient. This will not be helpful for precision medicine, as this person thinks. So I'd like your comment on that as well, but we'll just a few more things. How can scientists, clinicians, and I suppose people who work within government circles, how can we make the messaging to government to try and push this forward on the legislation level at that level? I suppose is probably the cumulative question from that. So we'll start with Sue.
Sure. Well, I would say as part of that legislation, precision medicine would have to be part of that messaging and marketing on health. That is the state of the art of the science. As Alex said, it's the state of the art for many other disciplines within medicine. And it's actually malpractice not to treat the right bacteria, not to actually look and see, or maybe not that's the exact example, but if you don't define what you're targeting, how can you target it? If we don't have the knowledge base, that's one thing, but as that knowledge base is evolving and developing, it needs to be integrated, it needs to be studied, it needs to be researched independently, and we need to see replication across different studies. But once we have that science in place, it must be translated into clinical practice, approved, and then legislation. And so I think part of that process is, again, aligning the research with the education, the communication, because the field is evolving, and so there needs to be opportunities for clinicians to train and retrain, and there needs to be that communication with those in place to make these legislations.
Yeah, I think accelerated pathways as well. I think Alex's example of ketamine in practice, and I know how hard ethics would have been to get through for that one, I can only imagine. But building the evidence, even if it's small scale in parts, but trying to accelerate the communication of that evidence into the right bodies, and maybe that means getting them there on day zero, and maybe it's a DVA and TGA and MPS and type conversation, just so that they know it's coming and the evidence base is being built and grown upon as you start to make some real headway.
I would love to see language be taught and trained in different contexts. So we spend so much time in our own silo, and so we adopt our own language. Out there in policy world, there are different organizations and different agencies. We live in a federated country, Commonwealth and states, territories. They have different agendas, different priorities, and it's a shared health funding arrangement as well. How do we even speak and translate what is in our minds and now in our collective heads into the hands of policymakers for them to stand up in Parliament to argue the case for us and for the broader community? Translation of the sciences and the clinical needs into policy language is tough. It's tough. And even if you are a health practitioner who stood up and became a parliamentarian, it's still tough. I would love to see in Australia deliberate efforts in all of our disciplines to follow what the Psychiatry College in the UK has done and embed trainees within the legislative pathways so that we have time spent collectively, but also individually, within the legislative space, so we understand how governments work and how to promote things.
Sounds like a solid move. Okay, one more question here. So it was mentioned a few times here, and I think it's come up quite a bit in the press. Depression is no longer viewed as just a serotonin deficiency. So in light of that recent research, what will be given as replacement to those patients? I presume in this context it's the patients that's not working for. You've mentioned ketamine, but are there other switch tos after that initial serotonergic-based drug? Either of you can answer this one.
It's tricky. We're not quite there in the full translation to say that SSRIs, SNRIs do not have a place anymore. I think it still does have a place. Rather than the either or argument, it's more likely that serotonin is one of the many pathways that we are yet to unfold and see. We need to engage with the pharmaceutical space entirely so. We need to engage with the scientific and also the pharmacogenomic space entirely so. How we then tailor so that the individual has a particular form of an answer, whether it be psychotherapy or pharmacotherapy, that needs to be articulated better. We're just not quite there yet. So the net messaging for me is that we have a tool set that has served us okay for a while, and if an outcome measure is we have a set of patients with high-level symptomatology that's yet to have an answer for beyond the current state, we haven't answered that question yet, and that very much belongs to research still in play.
Yeah, and can I just add quickly
Please.
that this is, I think, where neuroscience can actually bring so much to understanding this discussion point. So what we've understood about the way that serotonin reuptake inhibitors work within the brain is that they're not reversing a deficit in serotonin, they're promoting plasticity and repair in the brain, and that's why it can take a couple of weeks to a couple of months to see that therapeutic benefit. But for some individuals that may not work, and there may be other treatments that are effective, and treatments like ketamine that have been mentioned today engage those pathways very rapidly. And so understanding the sort of mechanisms in place within the individual can help align the treatment to promote that brain repair more effectively and more rapidly.
We've focused a bit on depression today, so one of the questions is going to ask sort of about anxiety, I suppose. Are there similar type medical strategies for anxiety? Is there new things coming up to treat that anxiety? And anxiety in the workplace, are there different strategies than managing depression? So we'll start with you, Sharon.
Yeah, sure. Look, I think the newest, and it's not new by any stretch of the imagination, is coaching strategies. So more and more, and particularly with people entering the workforce. So if you think about the differences that our younger generations and the challenges they're facing in terms of job security, precariousness and nature of jobs, starting whilst in COVID and being expected to make social connections and interactions, because networking is so incredibly important as part of this, it has created, whether we call it short-term anxiety or just the nature of anxiety and how that symptomology is appearing in day-to-day stuff that you're doing. We are seeing a lot of that. And I think one of the really exciting things more and more organisations and workplaces are doing, I think, is that coaching model. So moving beyond your traditional employee assistance program to being able to reach in for coaching at different points in time. And so that's about knowing what triggers your own stress and anxiety. That's about behavioural modification and trying new tools and techniques beyond nutrition and sleep, which is all obviously very, very important and critical. But trying to personalise that to what makes sense for you and what makes a real difference.
Anyone else want to comment on?
Just to add to that as well, I think it'd be useful to take a longitudinal perspective. Anxiety disorders in themselves have a very long tail end. And if we consider the public epidemiological studies that well-known, Kendall et al. Have done these studies quite well. We know that if you're a 24-year-old person with anxiety, there's a very high level of chance that at 12 years old you had that anxiety at a diagnosable level. Certainly child psychiatry practice, if you have a 12-year-old presenting with anxiety, you can predict that at about 7 years old there was a divergence away from their usual trajectory. If we consider that every child lives in a milieu of influences, as well as the inherited influence as well, we might start to say that the school environment may be a bedrock of early intervention for anxiety disorders before adoption of common adaptive and less so maladaptive pathways into the workplace. Early intervention for me goes right the way back into family environment.
Sue?
No, I agree completely, and I would just add from that biological perspective, there are a range of physiological symptoms that are also occurring during any sort of episode of anxiety, increase in heart rate, changes in breathing, and so complementing the need to personalise that treatment and recognise that. We now understand that intervening at that physiological level as well can produce a feedback through that, those systems in place to recognise threat and recognise anxiety triggers and calm them down at a physiological level, which enables the individual to then go on and make those other changes, takes them out of that moment of fear and sense of threat. And so again, it comes back to understanding what is the risk factor for you as an individual, how can you better manage that, and how can you use biology to support building resilience.
Fantastic. Well, thank you to all our panellists for your time today and for giving it so generously. In the interest of time, I won't answer any more questions, but I thank you all for joining us today. I think mental health is something that affects each and every one of us, and the research here at the Queensland Brain Institute is critical for understanding how people develop mental disorders, as well as finding preventative pathways and personalised treatment solutions. We encourage you to consider supporting the research via the link on this or the QR code on the screen. We also invite you to come and visit QBI, meet the researchers and sort of see firsthand what we're doing here and some of the cool toys we use as scientists as well. Finally, You'll be able to watch the webinar using the same link that got you here to the live event. It'll be saved on there for you to watch later on. So thanks again for joining us. We look forward to keeping you up to date with all the research in this space in the future. Thank you.